I'm here to present my humble project after following, our first speaker. So my project is the impact of incivility on patient safety and looking at increasing awareness as well as offering, in this case, the user, the participant would be pre-licensure BSN students, the opportunity to use something called cognitive rehearsal response to address incivility. And I'll talk a little bit about that. Before I start, though, I want to acknowledge the School of Nursing and Health Studies for, supporting and funding this project. I would also like to acknowledge Max and Komal. Those are the developers that I've been working with in order to bring this project to reality. So the overall aim of this project was really to increase awareness of incivility in healthcare, how it impacts patient safety, and again, teach students, give them a strategy such as cognitive rehearsal strategy to really address incivility among pre-licensure nursing students. And we were doing this in the context of augmented reality simulation. So uncivil behavior is associated with many negative consequences. I'll talk about a few. But first, what is incivility? So a lot of terms are used interchangeably. Incivility, you've heard of bullying, you've heard of what else? Harassment, lateral violence, horizontal violence, etc. So incivility, according to the American Nurses Association, is one or more rude, discourteous, or disrespectful actions that may or may not have negative intent behind them. Incivility is usually more subtle than the other terms that I just mentioned. So it could be verbal, it could be nonverbal, it could be things like marginalizing individuals. And so, unfortunately, incivility is found in all aspects of healthcare. You can see, clinical practice, research, academia, and for my project at this point, I'm focusing more on clinical practice issues that students may see. There's a lot of data out there about incivility and its consequences. I just have a few things that are here on the slide. So incivility is associated with 30 to 50% of new nurses exiting their profession within the first 3 years of practice. And I think that's really significant in terms of our healthcare resources. And you can see it's at an estimated cost that's quite substantial. Incivility, the target individual may have increased levels of stress, burnout, fatigue, absenteeism, turnover I already mentioned before. Also patient safety, which is really a particular interest of mine. So a lot of research has been done in that area, and patient safety, does jeopardize, thank you, it's a Friday afternoon, patient safety. In particular, the research shows that when you have a culture of silence that oftentimes we still have in healthcare and in other areas of healthcare practice as well, when you have silence, a culture of silence, people are afraid to speak up. And the research really shows that that impacts patient safety in a negative way. In addition to that, what I thought was very interesting when I did my original lit search on this topic was that a lot of studies have also shown that individuals who are experiencing incivil behavior may experience decreased cognition and ability to problem solve, to conduct skills, to carry out activities. And again, how that could possibly impact patient safety is very significant. So I talked a little bit about incivility, but cognitive rehearsal, that's a behavioral strategy that is utilized to allow someone to basically practice scripted types of responses. In this case, cognitive rehearsal, and it's been used by Cynthia Clark quite a bit. She does a lot of research on incivility in healthcare. And the purpose of the cognitive rehearsal, again, is to provide tools, strategies for, in this case, the targeted audience, at least initially, will be the pre-licensure BSN students, the opportunities to respond to this incivility. So there's different models that can be used. The model that I want to use in this project is actually the CUS model, C-U-S. It's a model that was derived from the Agency of Healthcare Research and Quality Team Steps model or Team Steps program. And CUS, or the CUS model, stands for concern, uncomfortable, and safety. So basically it can be one or two, two sentences, 3 sentences, where you have the person practice this, and it's, cognitive behavioral strategy, to talk about I am uncomfortable, or I'm concerned, excuse me, I'm concerned about such and such, I'm uncomfortable, and this is how I feel it impacts patient safety. So that is the use of cognitive rehearsal. And then augmented reality, we've learned a lot about augmented reality today, far more than I could ever tell you. So in terms of where is this project? So it's under construction. We're in phase 1. So when I started to meet with Komal and Max, the project was broken up into different phases. So phase 1 is really completing 2 scenarios involving healthcare professionals. However, phase 1 does not allow for the participant, which is the student, to actually have voice interface at this point. So instead, the use of avatars is being used at this point in time. So the student will view the scenario and be given the ability to identify uncivil behaviors. This is phase 1. Phase 2, now, in an ideal perfect world, the student's going to have the opportunity to interact with the environment and to actually be able to utilize that scripted content that I mentioned before, the cognitive rehearsal strategy. And the student will be in let's say, in a place in the simulation hospital, because this is augmented, and the student will actually be completing a simulation. So I'm interested in looking at if someone is, in the simulation and incivil activities or behaviors are occurring while they're being asked to calculate a medication or give a medication during this scenario. How is this impacting that? And how is that impacting patient safety? So a few things, just, very basic developmental considerations at this point. Frequent meetings are very important, I have found, because when I came to this project, I had what I thought this project would look like initially, and it has evolved over time and meeting, and that's been very, very helpful. So again, at this stage, the student will not be interfacing directly in the scenario itself, so we have to use avatars. So just some things that have come up, considerations for the avatars themselves, making sure that I'm addressing gender, ethnicity, those types of issues to really emulate, realism, etc. So this is just a screenshot of, this is not the avatar, this is the screenshot. So the way that the developers have approached this is, at this point, they're using it, the student would have on the goggles, the student would have the controller, and then they would enter into the actual scenario through this mainframe page. And I'll show you a very short video in just a moment. So just implementation, I hope to be able to implement the pilot testing of the first rendition in the summer 2020 with some of the BSN students, just phase 1 at this point. But as I mentioned before, there's several research aims. I'm interested, do students accurately identify incivility to start with? Do they even understand what incivility is, and can they identify it? Are they, again, this would be further down the line as this matures, are they able to actually utilize the cognitive rehearsal strategies when they're actually participating in the simulation? And what are the participants' perceptions of how it has impacted their safety and their practice? Our simulations are all videotaped, so I would also be going back and looking at the videotape and using a tool that was developed for another pharmacology study to determine if they are making errors in medication administration process, for example, and how that might impact it. And then, of course, pre-post-test design, looking at, their knowledge acquisition overall. So some of this still needs to be flushed out in terms of the research component. Generally you start with the IRB early, but what I've tried to do is hold off just a little bit to see what the product is actually going to look like, so that I can then, make sure that I'm addressing the actual product and not maybe what I visualized initially. So these are the references, and then I was going to try to just show you a couple of minutes, the first 2 minutes of, and I don't know where Robert put that. Hi, Robert. Is it on the main? Is it in the folder? Okay. Okay, so just to give you, can you stop it just for a second? Just to give you, just for a second. This is actually Kamal. It's a rudimentary video of what she was wearing the goggles and what has been created so far, okay? So this would be overlaid on into the actual simulation hospital.
Good morning, Mr. Smith. How are you feeling today?
I'm feeling much better today.
What medications did Mr. Smith get last night?
Mr. Smith received Tylenol at 10 p.m.
Oh. So I have to go back and meet with them so that stop it at this point. So that's the first. So that's again very basic in the beginning phases. So for example, now I just received this the other day, so I have to go back and talk to Max and Kamal. Was it really supposed to be quite that dramatic? So sometimes when we talk and we storyboard, then after you see the actual project, you have to go back and kind of make changes. For example, like in the beginning, some of the avatars had the old nurse's cap on, and things like that. And so we try to upgrade that in the bus. So that's the beginning of the project on page 30. I don't know if anybody has any questions. Okay, thank you.
Can you guys hear me? Good. So I tend to walk around a lot, so I make sure not to go in front and get blinded. My application is probably a very different twist on things. So I'm looking more kind of clinical applications of it. So trying to use the change the viewing platform basically from what we currently do and see if we can do it in a better way. So really what I'm looking at is kind of utilizing this augmented reality headset to change in how we do things. Okay? And actually listening today kind of opened up, I think, the possibilities of what we can do, really expanded that. So my wish list is increased quite dramatically. Obviously, I'm not getting paid, nothing off label. Purpose of this really is, again, trying to create a different viewing platform. So using ultrasound, typically what we're doing is we're trying to position the screen, the ultrasound screen, in such a way that we can actually visualize it and then perform the sonography, perform either the procedure or the point of care viewing that we're using it for. It's not always ideal. It's not always in the best position. So a lot of times what we're doing is we're very ergonomically uncomfortable, not in correct positions, and that can lead to neck pain, arm pain, a lot of sequelae from that. So trying to see if we can improve that. So, and that's the big thing that got me thinking here, thinking about that learning platform or changing that viewing platform. And what kind of expanded or opened my eyes today is that I think initially this is kind of a rudimentary application of it. But think about it, if we change, so what I want to do is basically live stream the image from the ultrasound screen to the headset. So you put the headset up, and then what we do is we'd be able to see through the headset the ultrasound image and see the patient at the same time. So we see the image and we can see through it and see the patient. So if we're doing a procedure, instead of having to look at the ultrasound image and say I'm doing a regional anesthesia, some nerve block, I'm in anesthesia. So we're doing a procedure, we have the ultrasound probe here, we put the needle in, we get to see the patient, but now what happens, we're looking up at the screen, we're no longer looking where the needle is. Well now, if we can look and see where that is and see the ultrasound image here, we're not having to actually look between the two. We get to see both at the same time. So I think that's the interesting thing. If we can live stream that to the viewing platform, then it doesn't really matter where the ultrasound machine is. It's irrelevant, right? We could just place in the corner. The other is that if we want to be able to make changes to that, we want to change gain, we want to zoom, we want to change the depth on that, to be able to do that on the headset. So if we could augment some of that process or be able to automate some of that process, so we can do that there. So it's really just trying to, again, eliminate the machine and just put that viewing platform onto the glasses. That's the kind of the whole goal. The other is, if you think about it and just talking, is the whole AI component of it. So a lot of what we're doing is we're trying to interpret images. Well, what happens if we can automate some of that? So, and some of it is calculations. So I know GE is a big player in this, and what they're doing is, say you are doing a transthoracic echo. Now you're trying to calculate an EF on somebody, so ejection fraction. What happens is the computer or the ultrasound machines now will automate that and automatically calculate it for you. So the same thing is now, instead of relying on the machine, the headset automating a lot of that stuff. So that really the platform doesn't matter, is you're creating a lot. So for example, say you're doing ultrasound and you're trying to assess gastric volume. Now, this could be for any calculation we're doing. Having the headset actually, once we get the view that we want, then having it automate it and actually calculate the volume that we, instead of us having to go in to figure it out. So that would be kind of an example of how we could use AI for that. And then the other is, right now for teaching, what we do is we have a Sonos simulator. So what it is, it's basically a simulated ultrasound, and we can do pathology. It's used for training. Well, what about combining that with the headset? Because right now what we're doing for training is we're having the students use that simulator. Now it's a probe, it's an ultrasound probe that's hooked to a computer, so it's just a USB port. It's not an actual ultrasound probe, it's simulating it. Then what we need to do is then take them over to a real machine and then have them do them live scanning. Well, why not combine the two? So now basically we have a simulator as well as we can live scan. So we could actually then augment pathology on there. So while they're scanning and scanning normal pathology and looking at the lung, and what we do is we look for lung sliding, we could also then simulate what a pneumothorax would look like, and they could actually see that while they're live scanning. So I think for the educational component, and these are things that are just kind of coming to with this discussion, I think that's where the huge potential is. And then the other is, think about protocols. So say you're a clinician, you're in the ER and you're doing a fast scan. Now you're following a protocol. So the ER physician, the nurse practitioner, it walks you through the protocol. And then as you're doing each system, so you're looking at the heart, save an image, capture that in the protocol. You're going looking at the right upper quadrant, save them in your protocol. And that could then be connected with the electronic health record. So the EHR automate a lot of that process. So I think it's really interesting what the potential is. And I think this is just kind of a beginning and kind of a rudimentary. Really wasn't sure what the capabilities of Magically were. Now knowing that, I think it really expands the potential. So here's just an example. You can see ergonomics. You can see how they're stretching over the patient. Not really ideal. So not very good viewing angle. Also, you can see some stretching of the arm. You could also see some lower back pain probably. The neck is also not ergonomically correct. So this is why it matters. If you look at sonographers, big percentage of those, you can see over 80% have musculoskeletal issues, right? Comes down to, again, 74.6 suffer shoulder pain, neck pain. So now this is pathology. These are symptoms now that are becoming because of poor ergonomics. So by improving that, are we able to lower some of that sequela, some of those issues that are happening? This was just pulled out of a study now looking at texting, right? So there's research that's coming out to show that, again, look at the neck flexion or look at the extension of the neck and how much pressure that puts on there. And again, that's leading to issues. So part of it is, again, if we can improve those ergonomics, hopefully we decrease some of that that's occurring, right? Such as disc herniations. Okay. This is one of the solutions in the industry for sonographers, is what they're trying to do is create a more ergonomic environment. So a chair that's platform that's a little ergonomically. Problem is for a lot of providers, we're bringing the patient or we're bringing all that stuff to the patient. So we don't have the I think, luxury of having some kind of platform like this. So it's how can we make that bedside, improve that bedside use of it. So here's the big thing. So what essential functions? Well, it doesn't have to be mind rate, but that's just the machine. Now we have SonoSim or SonoSite, I should say. But now, again, it's really any ultrasound machine trying to connect. So first one, and that's really where we are right now, is testing that out. And that's kind of the struggles we're having a little bit, is to live stream that so that there's no lag time. And I think maybe that second generation is probably, sounds like maybe a little more. But trying to, again, mirror cast that right to the headset without having to hardwire. Dual viewing. So again, I can see the image as well as I can see through, and then be able to allow video capture. So if we can videotape that, or at least take a screenshot of that. Because again, now that if you think about the ergonomics of it, part of that for billing purposes is you need to capture a video of it, or better if you can get, or I mean, at least an image of it, or if you can get a video of it to include in your EHR so you can bill for it. So that's a requirement for that. So here's basically what you do. You take the ultrasound image. Again, we're going to use the headset. So now we can try to at least see that image while we're doing it on that headset. And again, this is the one that's kind of blowing up now after hearing this discussion. I think those nice to have functions have just expanded a lot more, you know, with the interest of AI. Thinking about if you're doing a transthoracic echo on somebody, having the ability to have a cardiologist there to help you interpret that image. Say you're seeing somebody that's coming preoperatively and they have a low ejection fraction, and I go in there and I look at their cardiac function and I go and do a transthoracic echo. I can also then pull up their last one and see that image and compare them side by side and see the wall motion side by side active as I'm doing it live, right? Wouldn't that be amazing? That's, I think, the potential. That's I think, what's exciting. And again, really just kind of bypassing that poor design, improving the ergonomics. And hopefully what that does is then again, decrease some of those symptoms people are having, you know, decrease some of that pathology. That's it. Thank you.
Well, good afternoon. I also move around a little bit. I'm Juan Enrique Gonzalez, like Dr. Clausi says. I am in the anesthesia program, and I am the primary faculty in the development of this device, of this application, but I didn't do this by myself. I want to also thank Dr. Vladinov, who is here, and Dr. Hoglund, who's here, and Dr. Linda Wander and Dr. Nikki Gonzaga, who were involved at the very early stages of what we were designing. So this is actually in the website for Innovate, the group that Max Cascione leads. And I also want to thank them for their impressive support. The technical support was very important for us. So back in the summer, we saw the opportunity to begin using Magic Leap. And we said, well, how can we use this for the education of our students? So we thought about possible scenarios that we can use it in the simulation hospital. And the one scenario that perhaps became very obvious was, let's try to use this for prevention and treatment of fires in the operating room. It could be airway fires, or it could be fires somewhere else in the patient. As anesthesia providers, we are always in control of the amount of oxygen that we provide our patients. So in the triad of fire, oxygen is one of the main important components, right? The surgeon, when they're doing the surgery, they're in control most of the time of a heat source, a spark, right? And then the patient may be the fuel. So when we close that triad, we may end up with the fire. It's not something that happens all the time, and it's a good thing. But when it happens, it could have devastating consequences. So we said, well, let's try to see how can we modify the current scenarios that we use and use Magic Leap technology. What we had done before is we use a smoke machine, and we were hiding the smoke machine at the base of the bed, and we put a corrugated tubing somehow hiding and bring it next to the patient. We had a remote control that most of the time worked on time, and we click it at the appropriate time and smoke starts coming out, right? So again, this is one of those smoke machines that you can get at Party City or anywhere else. And you can imagine, the amount of smoke that sometimes comes is more than what you need. And sometimes that could set off the fire alarm. So we had to make sure that the fire marshals were here. They disconnected, all the fire alarms, make sure that nothing happened. And we told people, if you see smoke, don't call 911. So that's how we used to do this in the past. And it was very, very useful. We also had a secondary source of fire, which was somewhere away from the patient. And that was another smoke machine. But again, another control. Sometimes the controls didn't, talk to each other at the wrong time, and it could go off at the wrong time. So we had some limitations before. But it worked out pretty good. However, we saw using Magic Leap as a substitute of the smoke machines in the similar scenarios that we've been using. Not only to show an overlay of smoke, but now we could also show an overlay of actual fire, And we also decided in the planning stages to show an overlay of actual, water or saline, when this is one of the things that the surgeon or the anesthesia provider is doing, is pouring water with a water bottle. So we also figured out a way to show how that would look like. And another thing is, well, what about the fire extinguisher? Most of the time we use a fire extinguisher if it's a big fire in the OR, which is a water mist. So we also figure, well, maybe we can reproduce some kind of water mist coming out of a fire extinguisher. So we're combining reality with augmented reality to make it into a mixed reality. At the beginning, we were not sure how we were going to do this. Are we going to put a timer so that at a certain time the smoke goes off and then the fire goes off? That was the original. But as we know, simulation scenarios are very dynamic, and it depends on what the student does. So it wouldn't make sense to put a timer and something goes off at the wrong time. So we had to start thinking, how can we do this so that the instructor, the professor, has the control? So we figured that using the Magic Leap controller, that's how the professor is going to activate either the smoke or the fire or the actual water mist or water flow. So it took some thinking, because it was usually we're used to thinking about, I have the handset and I have the control as a student, but the student would not going to have the controls. We had to tell the instructional designers, no, the students are not going to be using the control. Their professors are going to use the control. So it was a little bit of a thinking out of the box, as this was designed to be used. We actually were able to go through IRB and do data collection for a pilot study that we're looking at, what is the feasibility from the student's point of view? How feasible are these goggles to be used in an actual training or education exercise? We collected some data there. It looks like the students are pretty much buying into it. They feel like it is a realistic approach. And we also collected data, recorded it about what is the performance like? Do they perform accordingly? Are they able to do what they're supposed to do? There were some issues that now, this semester, we're working out. We realized that there was a little bit of a delay in the actual image that came from the goggles into the control room. As the professor is sitting in the control room and is controlling what's happening in the scenario, the way the system is hardwired into the simulation hospital, there was a little bit of a delay. Now we fixed that thanks to Robert. Robert rewired the whole thing, and now we are able to see a more live feed, especially for the image that comes from the goggles. There was also another possibility that we thought about. What about having a second set of goggles that now not only the student sees what is going on when we activate the control, but maybe another set of goggles seeing the same thing that the student is seeing. Because otherwise we are depending on if the student is looking at it or not. If we activate something and the student is not looking there, how do we know that it actually did what it needed to do? An intermediate solution that was developed by Kamal and Max to do this is to have a color-coded label that when the professor activates the smoke, even though the student may not be looking at the smoke right there, we see the color in the corner of the screen. So we know that it's there. So it's an intermediate solution in the meantime until they are able to put a second set of goggles, which is the idea. Two possibilities: a second set of goggles by one of the instructors playing a role, or even a second set of goggles in a neutral position in the rooms that everybody can see from the control room what the overlays look like when they're activated. So this is how we were at the beginning developing this and telling the instructional designers how this was going to look like. But let me scroll here, and this is on the website. Here we have a video in which we have Dr. Nikki Gonzaga playing the part of a surgeon. This is supposed to be a tracheostomy. A patient is intubated, and now the surgeon is working to remove that tube and put a tracheostomy tube. I'm playing the part of the student with the goggles there. Dr. Blydenov is in the control room controlling the mannequin. So it's a whole production. And Dr. Linda Wander is in the room playing the part of the nurse circulator, the nurse that is assisting with the surgery. So we'll see some of that in action there. I may have to speed it up a little bit here and there, but you'll get an idea what it looks like.
your circulator, RN.
I'm Juan Gonzalez. I'm the nurse anesthetist.
Dr. Gomez, surgeon. And
So this
we
is
have,
what happens in the OR at the beginning of the surgery. People talk about what they're doing, what the roles are, and things like that.
And we are doing what procedure, doctor?
Tracheostomy.
And he has no allergies. He was given antibiotics.
Yeah, answer 2 grams given, IV.
Any concerns? The concern I have is the high risk for fire at a rate.
Notice how Dr. Wonder has the control in her hand. High risk of fire, so I have water here ready. Now, this is how we tested this as a prototype at the beginning. When we actually implemented these scenarios with the students, the controller was inside the control room with the professor that was doing the scenario. Right now, going at FiO2 of 100%. So right now we're starting with the high oxygen concentration, and the main issue here is communication. To be able to communicate, if the patient is the surgeon and the anesthesia provider not communicating clearly, the patient could be at risk. So this is not only technical issues, but non-technical skills about having a plan, having
I believe so.
communication clear between the providers.
Night back on the field. Can you turn up my Bovie to 30?
So when we did it with the students, we had the student at the helm being the anesthesia provider, and we did this for all 35 students in that class. We did it in three weeks, 1 week, one group, another week, another group, and groups of 10 at a time, or 12. Yeah, about 30 seconds or so here more. So they're discussing here because the saturation of the patient, started to go down, and they're communicating, but notice how the surgeon continues. In a few minutes here, you'll see another screen that pops in here, which is an overlay of what the actual goggles view is like. It's doing good, it's 98%. Blood pressure is good, 119/79. Seems to be comfortable.
Still a little oozy.
Yeah. See, moving a little bit. Hang on, let me give you some more.
Little light, yeah.
Let me give you some more here. So I'm going to advance a little bit.
Time start was 12:36.
Still a little bit oozy. Can you go up to 50/50 on the Bovie?
So the surgeon is asking to increase the intensity of the device that is used to cut and burn, called the electrocautery device.
50/50, Bobby.
Thank you.
So notice how the saturation begins to go down.
Yeah, his saturation is going down a little bit. Let me put him up.
You can hear the tone. It's now back to 87%.
See what's going on. Let me take him off the bed momentarily.
Pretty soon you'll see here
See what's going on here.
an overlay.
Let me just get a towel here. Let me know when I can.
I'm gonna take a listen from this side here. Yeah. Yeah, breath counts are bilateral. Going up a little bit there. You can probably go ahead. I'm gonna put him back on the bench.
Notice the instructor on the side that had the control.
It's a 92. He's not holding very well, but you can probably go ahead and continue.
To give you an idea what the scenario looks like.
Yeah, let me go down to 30% again.
Okay, great. We're still at 50/50?
Yes.
Okay, great.
So the surgeon now continues to use the device without communicating properly.
I'm gonna go up with the 70. I'm gonna go up here a little bit higher. Yeah. Oh, I see some smoke here. 1 second.
That's the view from the
I see some
Magic
smoke.
Leap.
I'm gonna take this straight out.
Okay.
Probably just take a look at what's going on here. And put it Just, can you take those drapes out there, please?
So you notice how
Yeah, just get out.
if you had a second set of goggles, you have a continuous view of what's happening rather than depending on the person who's doing this.
Yeah, let me put some water here. Let me put some water.
So not notice the water.
Yeah.
So they go in here and you see the water
I'm
stream.
gonna go ahead and extubate, and we're gonna have to re-inspect the airway, see what's going on here. You have a light scope? Can you get CMAC in the room, please? Yeah, let me take a quick look there. Gonna have to extubate here.
You know, I'm gonna call ENT.
Yeah, look at that. It's very dark. Look, Doc. It's very sharp.
So that's inside the mannequin on the right side there.
It's very sharp. So I'm gonna extubate him. And
Is there a fire in the drape?
yeah, the drapes. No, the drapes are okay.
So remember, the drapes were removed and we'll put to the side. And now as they're concentrating, working on the upper part here, you will see how a secondary fire works.
Go ahead and pull it. Okay.
A bigger fire. So the primary fire was in the airway.
Yeah, let me take
They're dealing with it right now. And as they remove the drapes caught on fire next to the patient. But they're not seeing it yet.
Oh my goodness.
Oh my goodness, fire in the drape.
So that's a secondary fire on the side.
Can somebody get the fire extinguisher, please? Fire extinguisher there.
There's a fire in the OR.
Yeah.
You see the
Huge
huge fire now.
Extinguisher. Yeah.
And notice how you will see now in a couple of minutes, there's a little delay because of the image was not coming at the same time. But you'll see now when you see the water stream.
Okay, do we need to evacuate the room?
So that's what the anesthesia provider is seeing from the helm, where the fire extinguisher is being activated.
Yeah, it's very smoky.
It's very smoky here, very getting unstable. It's gonna be unstable.
Call the bed for transfer back to ICU.
Right. So that gives you an idea of what the scenario looked like when we did it. And we still have to fine tune a few more of these. The students loved it. They got into it before they started using the goggles. We had to make sure that they understood, what it would look like. So we did some training before because they never used the goggles. We also had to calibrate in between scenarios that the source of fire will be coming from the right place because the mannequin will be moved a little bit when they're intubating or extubating, and then the fire may be coming from here as opposed to here. So we learned that we will recalibrate. And these are things that we continue to learn as we work the scenario. But again, this is a great opportunity to use Magic Leap goggles in a mixed reality in an interactive scenario to train the students to hopefully prevent fires. But if they do happen, then they know how to treat it. They know how to manage it. Thank you very much.